Hey, good evening. Thank you all for coming. My name is Mike Christie. I'm the oldest of the joint replacement surgeons in our group. The only one with the gray hair, I believe. Tonight we're going to talk about joint replacement, and I think importantly, we have three patients that will be here to answer questions. They're going to sit on a panel after we give a couple of short, brief talks to help answer the questions that many of you have. As you get into this with hip and knee arthritis and shoulder arthritis, it gets very confusing. You see things in the newspaper and on TV about fabulous new things and surgery that doesn't hurt and is done as an outpatient and all kinds of remarkable things. And most of them, of course, are exaggerations of what reality is. And so what we hope to do tonight is to give you a good idea, a good sense of what joint replacement is and what it can offer you in terms of relief from your symptoms. And I think probably the most effective people to tell us about that will be those people who have already gone through it. So we're going to start tonight with Dr. Morrison. He's going to talk a little bit about what arthritis is and what some of those myths are.
Thanks everybody for coming. My name is Craig Morrison, and I joined the practice about 8 years ago, and my talk is going to be about some of the myths and misconceptions that surround joint replacement. And fairly small group tonight, so we want to definitely make this informal and leave lots of times for questions. When you ask a question, usually means at least 4 or 5 other people in the audience are thinking the same thing, so then we can answer everybody's questions at one time. First thing I want to talk about, I think many of you come with some knowledge about arthritis, what it is, and what a joint replacement is, but just a couple of slides first on what arthritis is and what joint replacement is. If you see this slide on the left, it's a long standing x-ray that we take on all of our patients that goes from the hip down to the ankle. And if you center in on the knees of this patient, both of them towards the inside are what we call bone on bone. And arthritis is a wearing away of the cartilage surface that covers the bone. So when we take a standing x-ray and we see space between bones, we know that there's cartilage on the end of the bones. When we don't see space, we know there's no cartilage, and that's what arthritis is. So the diagnosis actually is fairly easy from an x-ray standpoint, and we like for all of our patients to be able to see that because it is fairly straightforward. And then on your right is the same patient after knee replacement. And what you see is that it's not really a bionic knee. When we do a knee replacement, we don't cut the knee out and actually replace the knee. We replace the cartilage surface with, in knee replacements, metal and plastic, so when the patient stands, they don't have that bone-on-bone pain. The other thing that we do is reconstruct the joint and the alignment. So the patient on the left, before you see those lines that go from the hip to the ankle, it passes through the middle part of the knee or to the inside. And when it's reconstructed afterwards, that same line passes through the middle of the knee so that not only is the leg made straight, but the weight is distributed evenly on the outside and the inside so that the plastic wears slower. So that's a knee replacement. Where's Martha? No? She does. But that okay. Let's see here. Put up a different talk. We didn't want that though. All right, so a hip replacement is this. And the concept is the same. We see a patient here with a pelvic x-ray. On the left, that is a normal hip. Hip is a ball in the socket, and you see space between the ball and the socket, so we know that there's cartilage. If it had arthritis in it, we would see, like the knee, the ball rubbing against the socket, bone on bone. When we do a hip replacement, it's what we see on your left-hand side or the patient's right hip, where we replace the ball with a metal ball, but it has to be anchored to the bone in some manner. And in this case, it's anchored with a stem that goes down inside the thigh bone that the bone ultimately attaches to, and then a metal socket. So again, instead of bone rubbing against bone, it's two hard things rubbing against each other that don't have nerve endings and therefore no pain. So, some of the misconceptions or myths about joint replacement. One is, am I too young or am I too old? And we get that question a lot. And the answer is no, for both of them. We do joint replacement to make pain better in patients that have arthritis. In older patients, we have different concerns that we do in younger patients. In older patients, we do have concerns about the surgery itself and health problems, but age is just a number. And so age by itself does not make somebody unable to have a joint replacement. Okay? Older patients can have more health problems, and that's something that we pay a lot of attention to, but age by itself is not a factor. Young patients, we worry more about the life expectancy of the implant, and they're typically going to live a long time. They're going to put wear and be active on the joint replacement, and so we counsel them a lot about what you can and can't do so that the joint replacement doesn't wear out. This is another thing that we hear a lot. We get patients that come in and, I heard of a new joint replacement that's going to last forever. And the real answer is, if it sounds too good to be true, it may be. And typically new and improved don't necessarily go together. Joint replacements are something that we follow hopefully for decades. And we judge our results not only by the pain relief, but how long they last. And we only know that by how long they're implanted in somebody's body. So if something is new, we may not know that it's improved for several years. And our job as physicians, doing many joint replacements, giving talks, doing research, and going to meetings, is trying to pick out what we think the new technologies are that will be an improvement. And so if you hear something that's going to last forever, if your joint didn't last forever, it's a good chance that's not true. In regards to how long one will last, it's, will my implant wear out? Well, if you live long enough, anything that we put in that's mechanical will wear out. And a lot of it depends on how well it's put in, what it's made of, and then what the patient's activity is. And basically, we counsel patients on certain things to avoid depending on the kind of joint replacement they have in. This is a picture of two pieces of polyethylene or plastic from a knee replacement. The top one was in somebody for a while, but you can see the difference between the top one and the bottom one. The bottom one is clearly worn out. But what we know from many different kinds of implants is that over a 15 to 20 year period of time, we can expect sort of a mid to high 80% survival, even in younger active patients. So they do last for a long time, but they can wear out. In hip replacement, we'll talk a little bit about this and certainly take questions on the kind of surfaces we use, but some of the newer technologies that have been out 10, 15 years, which are new, do seem to offer a joint replacement that potentially has longevity that could even give 30 and 40-year-olds a hip replacement that may go the rest of their life and offer them function. So being highly active, cycling, and we see this patient on the right that's squatting down, and so the old restrictions of I can't bend over, I can't cross my legs for the rest of my life are not necessarily the case with some of the newer technologies. Well, what can't I do after surgery? Well, in hip replacement, it does depend on the kind of implant we put in. But like I said, with many of the newer technologies, there are no restrictions after the replacement. With knees, we still right now have to use polyethylene, which is that plastic that I showed, and it's certainly more susceptible to wear. So we typically counsel patients to avoid repetitive impact activity, specifically sports that are a lot of running or a lot of jumping. And so at the bottom there you can see we certainly encourage walking, hiking, cycling, swimming, elliptical trainer, things like that, and even some sort of lower impact things like doubles tennis, but maybe not getting back to competitive tennis. So these are things that you might not be able to do after surgery. But the real question is, what can you do after surgery? And if you're coming in thinking about having a joint replacement, it's probably because you are not doing many of the things that you want to do, even simple things, and walking in the mall. So these are the things that you certainly can do. Unlimited walking, swimming, cycling, golfing, horseback riding. A patient just came in here that was talking about weightlifting, and we do encourage lower weights. So you can get back to doing some weightlifting, but the repetitive high impact things are the things that we discourage. Physical therapy, and we have some therapists here, over here on the right. That is a big part of your recovery. What we do is sort of a short time frame in surgery, but what we do functions well because of therapy afterwards. And it has to be supervised by a knowledgeable therapist, but not forever. So once you get through the recovery phase, you don't have to have formal physical therapy, but certainly exercise is an important part of your joint health for the longevity of your replacement. And we do find year after year, as patients come back, the ones that have stayed active and kept doing some exercises, their knee or hip feels better year after year, and the ones that don't, they get a tendonitis here or something that we need to work on with therapy. So it is important to continue to do exercises. Is there a cure for arthritis that's not surgery? And the answer, unfortunately, now is no. Going back to that first couple of slides, arthritis is the wearing away of the cartilage surface on the bone. And we can grow cartilage in a dish in the lab, and we can even implant it into cartilage defects and get something like cartilage that grows back, but it does not hold up over time to the stress of joint activity. And so right now we cannot cure arthritis. We can only try to manage the symptoms. And these things below that you hear about sometimes, like the supplements, glucosamine, chondroitin, shark cartilage, etc., do not grow cartilage. And some patients, they help their pain, honestly, by a mechanism that nobody really understands, but it doesn't change the x-ray or slow down the progression of arthritis. And the same thing applies to certain injections, whether it's protein injections or corticosteroids. So right now we don't have a cure for it. When is it time for a joint replacement? Well, it has to do with quality of life. And we, kind of tongue-in-cheek tell patients that they'll know when they're ready. But the short answer is, when you have pain that is intruding on your daily life most of the time, is preventing you from doing things that you need to do every day, and certainly if it starts invading even your rest and your sleep, then that's probably a good time to at least consider it and investigate whether that's right for you.